Okay, so now the topic we will discuss is movement disorders. So, first of all, we'll understand some basic things about pyramidal and extra pyramidal system, which causes our different sort of symptoms. When we say extra pyramidal, what do we mean? We mean by involvement of the basal ganglia. We mean by the involvement of substantia nigra, subthalamic nucleus, these structures. And when we say it is the pyramidal system that is involved, we mean to say that it is the corticospinal or the corticobulbar tracts. Right. So pyramidal system is the corticospinal and the corticobulbar tracts. We all know what is corticospinal tract is and corticobulbar tract is. If you don't know, okay, then I have to tell you also. The corticospinal tract, it controls our trunk and limb. Okay, whereas the corticobulbar tract is controlling our face, head, and neck region. So corticobulbar tract controls the face, head, and the neck region. Corticospinal tract controls the trunk and the limbs. The corticospinal tracts, they go from the primary motor cortex to the spinal cord. So this is for the corticospinal tract. But the corticobulbar tract, they go from the primary motor cortex up to the brainstem. Brainstem, because brainstem has your midbrain, pons, and medulla. So they end in the brainstem, that is your midbrain, pons, and medulla. But the corticospinal tract, they go below, right? So this is your, suppose I'm giving a side view, right? So if this is your, this part is your midbrain, this part is your midbrain, this part is your pons, this part is your medulla oblongata, and this part is spinal cord. So suppose this is the primary motor cortex. Okay. This area is the primary motor cortex. From there, if the end is either in the midbrain or pons or medulla, this is a corticobulbar tract. But if it goes up to the spinal cord, then it is a corticospinal tract, right? And how and what does it control, we know. Okay. And see, if we look at the internal capsule, suppose these are the internal capsule, we're looking from the top. For the corticospinal tract, we have to see from the top. So if we see from the top, a side view, okay, this is the side view. Okay. Suppose this is the primary motor cortex. Okay, from the primary motor, this is the primary motor cortex, this is the primary motor cortex. Okay, from there, what comes out is the corona radiata. Okay, corona radiata goes to the, this is the corona radiata, and this goes to the internal capsule. Now now we are seeing from the top. Now we are seeing from the top, this is the axial cut section. So this is the anterior limb, this is the genu, and this is the posterior limb of the corona radiata. This is the right side, this is the left side, because we're looking from the top, like we are seeing a CT scan. So we are seeing from the top. So corticospinal tract, hair fiber goes through the posterior limb of the internal capsule. From here, the fibers of corticospinal tract goes, but the fibers of corticobulbar tract, they go from the genu of internal capsule. So this one is for posterior limb. We know that motor fibers goes from the posterior limb, and sensory fiber goes from the, so this is the descending part, this is the ascending part. From the anterior limb, the suppose this is the anterior limb and this is the posterior limb. From the anterior limbs, signals go up, and from the posterior limbs signals go down. But for the corticospinal tract, it is the posterior limb. For the corticobulbar tract, it is the genu part of the internal capsule. And sensory always comes from the anterior limbs. So you can see that the pyramidal system comprises of corticospinal and corticobulbar tracts. Again, pyramidal system composes of corticospinal and corticobulbar tracts, and they are part of your upper motor neuron. So if you have any involvement of the pyramidal system, you will have the upper motor neuron signs, and if it is involvement of the extra pyramidal system, then you will have the movement disorders like tremor, rigidity, bradykinesia, chorea, and dystonia. All these movement disorders are part of extrapyramidal system, and upper motor neuron signs are part of your pyramidal system. What are the features of upper motor neuron involvement? UMN signs. Okay, UMN signs. See, spasticity, hyperreflexia, and positive Babinski sign. These are signs of upper motor neuron involvement: spasticity, hyperreflexia, and positive Babinski sign. Upper neuron signs are seen in conditions of stroke. The person will have spastic limbs, hyperreflexia, positive Babinski signs. Fourth symptom of the upper motor neuron sign is weakness, which will be in the form of paraesthesia or paralysis, any of the two, paraesthesia or paralysis. Now once we know this basic information, now we'll start the most important topic of this chapter, Parkinsonism, the most important disease in this chapter of movement disorders. Okay. Parkinsonism, there are types of Parkinsonism: primary, secondary, atypical. Primary Parkinsonism is called Parkinson's disease. So Parkinsonism is of three types, and primary Parkinsonism is known as Parkinson disease, which is the idiopathic condition. And then we have secondary Parkinsonism and atypical Parkinsonism, which is known as Parkinson plus syndromes. So primary Parkinsonism is your Parkinson disease, which is idiopathic. Secondary Parkinsonism, which is mostly caused by drugs or toxins, and atypical Parkinsonism is Parkinson plus syndrome. Now, what are the examples of the Parkinson plus syndrome? Okay, you should know, and I'll tell you right upfront. बाद में हम लोग फिर डिस्कस भी करेंगे, later we'll discuss. Okay, these are multiple system atrophy, progressive supranuclear palsy, corticobasal degeneration, dementia with Lewy body, and vascular Parkinsonism. Let me ask you questions. Okay, what is the hallmark of progressive supranuclear palsy? Okay, tell me, what is the hallmark of progressive supranuclear palsy? Can you remember? It is vertical gaze palsy. ऐसे क्वेश्चन आएगा, what is the hallmark of progressive supranuclear palsy? The answer is vertical gaze palsy. Okay, vertical gaze palsy means the person cannot look upwards. Okay, the person can't look upwards. Vertical gaze is paralyzed. So he will look always downwards. Okay. Next question. Hot cross bun sign. Hot cross bun sign on MRI. BUN bun. Hot cross bun sign on MRI seen in. Okay, I'll give you option. Hot cross bun signs. Obviously, first one is Parkinson disease, multiple system atrophy, PSP, and CBD, corticobasal degeneration. Where we see hot cross bun sign. Hot cross bun is seen in MSA. MSA specifically, the answer is MSA type C. Okay. But just remember, hot cross bun sign is seen in MSA. We'll discuss MSA type C later. Okay. Which Parkinson, question number 3, which Parkinson plus syndrome is most commonly associated with visual hallucinations and fluctuating cognition? Which Parkinson plus syndrome, which Parkinson plus syndrome, which PPS, Parkinson plus syndrome, is associated with early hallucinations and fluctuating cognition? Tell me, is it CBD, is it MSA, is it diffuse Lewy body dementia, or PSP? So early hallucination and fluctuating cognition, these are features of diffuse Lewy body dementia. So diffuse Lewy body dementia, here dementia onset is early. So because of dementia, there is early hallucination, fluctuating cognition. Dementia हो रहा है ना, so cognition will get impaired. So fluctuating cognition. Question number 4, easy question. Hummingbird sign on MRI is seen on. It's a lateral. When we take a lateral section of when you're seeing the sagittal images of MRI, you will see the hummingbird sign, and this is sign also known as penguin sign. It's named after a bird, hummingbird or penguin sign. Okay, this is due to why this happened. This hummingbird sign or the penguin sign is due to midbrain atrophy. This is due to midbrain atrophy. The midbrain is atrophic. Because of that, what happens? Suppose this was the midbrain, this was the pons, this was the medulla, this was the spinal cord. It was looking like this. It was looking like this. But now because of midbrain atrophy, midbrain is very small. Pons, medulla, and now see. Now look how it looks. See, this is the thickness of the midbrain. Now see the thickness of midbrain. This thick part of midbrain looks like the beak of the bird. So hummingbird or penguin sign, midbrain atrophy. This is seen in which condition? Which Parkinson plus syndrome? PSP, progressive supranuclear palsy. Now tell me, what are the types of MSA? What are the types of MSA? MSA is of two types, MSA-P and MSA-C. Parkinsonism predominant and cerebellar predominant. So P is Parkinsonism predominant and C is cerebellar predominant. So two types of MSA. Now previously it was of three types, MSA-A, MSA-P and MSA-C. A is no more included. It is considered as a separate condition known as Shy-Drager syndrome. So now it is only MSA-P and MSA-C, Parkinsonism and cerebellar. MSA-P is Parkinsonism predominant, MSA-C is cerebellar predominant. And this MSA type C, in this we see the hot cross bun sign on MRI. This is, if they ask you the hot cross bun sign, that we see in MSA type C. So it is MSA with predominantly cerebellar symptoms, is due to degeneration of which fibers? They give you options like substantia nigra, midbrain tectum, cerebellar cortex, pontocerebellar fiber. What is your answer? The hot cross bun sign on MRI, which is seen in MSA type C, is due to pontocerebellar fibers degeneration. So degeneration of these fibers, pontocerebellar fibers, is responsible for the hot cross bun sign on MRI in MSA type C. So hot cross bun sign is seen on MRI. It is seen in MSA type C. It is due to the degeneration of the pontocerebellar fibers. So let us talk about MSA. You know MSA is of two types, MSA P and MSA C. So in P, the predominant features are of Parkinsonism. In MSA C, the features are predominantly of cerebellar features. But that doesn't mean that P does not have C symptoms or C does not have P symptoms. It is predominantly the symptom. Parkinsonism symptoms and cerebellar features, they are both seen, but predominantly Parkinsonism, predominantly cerebellar features. And what is also associated with MSAP and MSAC is autonomic dysfunction. Autonomic dysfunction is seen with both. Okay, autonomic dysfunction is seen in both MSA type P and MSA type C. Autonomic dysfunctions. Examples of autonomic dysfunction. Autonomic dysfunction, you know, orthostatic hypotension, then urinary incontinence, then erectile dysfunction, sweating abnormality. So orthostatic hypotension, urinary incontinence, erectile dysfunction, sweating abnormalities, these are all features of autonomic dysfunction. And when you have autonomic dysfunction, along with that, either predominantly Parkinsonism feature or either predominantly cerebellar features. Cerebellar features like you have ataxia, nystagmus. Okay, ataxia. Cerebellar features are what? Ataxia, nystagmus. Okay, dysmetria, dysarthria. These are all cerebellar features: ataxia, nystagmus, dysarthria, dysmetria. Dysmetria means how much you have to throw something. You cannot decide. Either the person will overshoot or undershoot. Okay, so key feature of dysmetria is the patient is unable to control the force while throwing a movement, while throwing something towards a direction. So inability to control the force that is required to throw an object towards one direction. Either it will overshoot or undershoot. Overshoot is hypermetria, undershoot is hypometria. Hypometria together, dysmetria. So dysmetria is easily seen with finger nose test. You tell the patient to touch their nose, either they'll overshoot or undershoot. So think example of how to detect the dysmetria: finger nose test or heel sheen test. Finger nose test, very easy. Okay, this is dysmetria. And dysarthria means a condition where the person is speaking less. We are no. So what kind of speech is? It's a robotic speech. So dysarthria is robotic speech. How does robots speak? They speak slow, okay, and they are very slurred voice. So slow, slurred, so this kind of voice is dysarthria. So dysarthria and dysmetria. Ataxia and nystagmus, these are all cerebellar features. So you will see the cerebellar features and also the Parkinsonism features, but autonomic features you'll always see. The urinary incontinence, orthostatic hypotension, erectile dysfunction, sweating discomfort, sweating abnormality.